At Wakefield Orthopaedic Clinic, we're a group of 16 surgeons based out of Wakefield, Calvary Adelaide Hospital. We cover all parts of the upper and lower limb. We do visit the regional centres in South Australia as well, but we also consult and operate in multiple locations. You can head to our website to find our surgeons and their locations. I'm based out of Calvary Adelaide Hospital and also Woodville with a GP practice out in Port Road and Modbury with the PhysioFit team, and also in Berry, Narracorde and Mount Gambier. So just looking at shoulder pathology and a bit of the anatomy that goes with it. The shoulder is a ball and socket joint, and it's made up of the humerus, which is the arm bone, coming up with the ball part at the top of the shoulder, top of the arm into the shoulder joint, connecting with the glenoid, which is the socket part of the scapula or the shoulder blade. And this forms the ball and socket articulation. As you can see, the ball part is actually quite a lot larger than the socket part, and so it relies on the soft tissue parts to hold the ball and the socket together. And this contributes to a lot of the pathology that we see with shoulders. There's a lot of stress that occurs through the ball and socket joint, and the soft tissues are really where that stress is felt. The majority of the shoulder movement is enjoyed through the ball and socket joint, and 1/3 of the movement is between the shoulder blade and the chest wall. The problem is that if the muscles supporting the shoulder blade aren't working, the entire shoulder will really stop working appropriately. And so a lot of the physio activities and exercise that we focus on are engaging the shoulder blade muscles to give you a good base for the shoulder to work from. And if that's not working, then we're going to continue having rotator cuff, long-headed biceps, and other muscle issues around the shoulder joint. As you can see from these pictures, when the shoulder's working well, it's an amazing joint. It gives a great arc of motion, taking your hand really in front of your body, around your back, up and over your shoulder and above your head height. And it also creates rotation. But when it stops working properly, either because there's a bone or joint problem, or if there's a soft tissue problem, it's a grumpy joint. It takes a long time to get it working again. And even after surgery, it takes extensive rehabilitation to have your full return to function. Just a quick look at some of the common parts of the shoulder joint that we talk about. Looking at the rotator cuff, which is such a common part of the shoulder to have injuries within. The rotator cuff is made up of the subscapularis, which is the muscle and tendon unit at the front of the shoulder. At the top, there's the supraspinatus tendon, which is the most commonly torn rotator cuff tendon. You can see in the bottom left a tear across the supraspinatus tendon here. And then at the back of the shoulder joint is the infraspinatus and teres minor. These two back muscles are really important for rotation control of the arm at the level of the shoulder joint. And so a lot of the physio-based work is to engage these back rotator cuff muscle and tendons to give you good shoulder control. You can see in the diagram at the bottom right, this is with the ball taken away from the shoulder joint. You can see the socket there, which is increased in its size by the labrum, or the soft cartilage of the shoulder joint. And then here is the long-headed biceps, which is also an important structure, but also a pain generator within the shoulder. These bones here are part of the acromion and the coracoid, and they support the arch of the shoulder. There are also muscles on the outside of the shoulder which can give you pain symptoms. There's the long head of biceps, which comes up from the arm, and the tendon itself enters the shoulder joint. When there are tears or inflammation in the rotator cuff alongside the long head of biceps, that can generate significant pain felt in the front of the shoulder joint. Additionally, there's the pec major tendon, which is a big sheet muscle that comes off your breastplate and your collarbone to insert on the top of your arm. And this can be injured, particularly when doing things such as bench press with excessive load, and that can fail as you're trying to contract that muscle. You can additionally get inflammation and partial thickness tearing in that tendon, and that can generate pain in the top and front of the arm. The trapezius and rhomboid muscles are important for stabilizing the shoulder girdle, or the shoulder and the shoulder blade to the chest wall. once again, working to give you a good base for the shoulder to function from. So just recovering some of the work that Karthik discussed, rotator cuff tears are such a common presentation, and by the time you reach 60 or above, you really have at least a 1 in 2 chance of having a tear in your shoulder. Not everyone with a tear in their rotator cuff has pain. So tear doesn't necessarily equal the cause of your pain. And it is a common finding for a lot of investigations across the shoulder for anyone that comes through our clinics. Often people or patients of mine present with nighttime pain. Unfortunately, this is a poor prognostic indicator for achieving good pain relief and return to function without surgery. Traumatic tears are less common, but when they do occur, they're often associated with dislocation of the shoulder joint. In those cases, you're more likely to have a tear at the front of the joint rather than at the top. These are some pictures of the long-headed biceps, which is the biceps muscle sits in the front of the arm, and the long-headed biceps comes up the front of the arm and into the shoulder joint. And the picture on the bottom left is an arthroscopic picture or keyhole surgery photo, which shows the long-headed biceps being wrapped around by part of the rotator cuff. And that just shows that intimate relationship between the biceps tendon at the front of the shoulder and the rotator cuff alongside it. The picture at the bottom right is a photograph of someone with a ruptured long-headed biceps. You can see the muscle of the biceps is sitting down lower in the arm, which is abnormal. You can get long-headed biceps instability, and you can also have that tendinopathy or inflammation within the tendon, which contributes to pain at the front of the shoulder. These are some x-rays here of arthritis or wear and tear of the shoulder joint. The picture on the right, you can see some extra bone spurs forming around the ball part of the shoulder joint, and this is a sure sign that there's arthritis within that joint. Again, the shoulder pain associated with shoulder arthritis is often worse at night time, activity related, and may become recalcitrant to medical management, meaning that it just won't go away despite taking pain relief, anti-inflammatories, and having attempt at physiotherapy. There are lots of causes for arthritis and wear and tear within the ball and socket joint of the shoulder, but they end up with the same result, which is a painful stiff joint. So generally, patients tell me, I've got pain. It might be described as sharp, aching, or a dragging feeling down the arm, particularly felt on the outside of the arm from the top of the shoulder down, and often felt worse at night time when you're lying on that side or the arm draped across the body. It may be described as burning or stabbing type pain, particularly with activities and when using the arm. Sleep is often the first thing to go with shoulder pain, and it can be very difficult to get the sleep back until the source of pain within the shoulder has been treated. Ultimately, patients tell me that their shoulder feels stiff and that they feel like their function is deteriorating. They can't do the things that they enjoy or work without pain. Karthik's covered a lot of the alternate diagnoses around the shoulder. From my point of view, I try and simplify things a little bit for patients and talk about the shoulder either being a pain problem in isolation, and this occurs when there is significant pain, but the shoulder maintains good range of motion. And for me, this largely represents a soft tissue problem in the shoulder joint. So it might be a rotator cuff problem, a biceps problem, a labral problem, or a bursitis or impingement problem. And then once we've got the diagnosis, we can work through a treatment program, hopefully solving those pain problems. If the pain is associated with stiffness, then that can direct us down one of two lines. Either the shoulder joint itself is worn out, and that's called arthritis, or the lining of the shoulder joint is stiff, and that's called frozen shoulder, and Karthik described that beautifully. That stiffness in the lining of the shoulder joint can take 6 to 24 months to go away, so that's 2 years to go away, often without particular treatments. But if things are getting very stuck, just as Karthik described, we can perform an arthroscopic or keyhole release of the shoulder joint in that occasion. I just wanted to show everyone a few pictures and concepts of shoulder surgery. This is keyhole surgery with the picture on the right side showing the camera going into the shoulder joint, and then another small portal allowing an instrument to enter the shoulder joint for us to work with. And that instrument there is designed to shave away inflammation and torn parts of the shoulder joint. We use typically 3 to 5 small incisions around the shoulder joint in arthroscopic surgery, and we use a combination of different sized and angled arthroscopes to get full view of the shoulder joint so that we can see the shoulder joint itself, the bone and the ball and socket parts, the labrum or the cartilaginous part in the shoulder, the rotator cuff, which connects the shoulder to the arm to the shoulder blade and drives a lot of the motion of the shoulder joint. And then we can go on and treat the problems within the shoulder joint. And the problems in the shoulder joint that are amenable to arthroscopic or keyhole surgery include treatments for the biceps tendon, either tenotomy, where we release the tendon from the shoulder joint, or a tenodesis, where we release it from the shoulder joint but reconnect it to the top of the arm. We may be able to perform rotator cuff tear repairs, take away the bursa, or what we call to decompress the subacromial space. If there is abnormal spurs within the shoulder, then we can take those away with the instruments. And in cases of instability of the shoulder joint, we can repair the labrum or the soft cartilage to restabilize the shoulder. This is a picture of some of the anchors that we use in this surgery. This is designed for rotator cuff tear repair. And the anchors themselves are made out of a type of plastic which has sutures attached to it and goes into the bone. Those sutures are then used to pass through the rotator cuff and then connect it back down onto the bone for it to heal there. These anchors and sutures are extremely strong, but it does rely, the long-term function does rely on healing of that tendon back to bone, which typically takes between 6 and 12 weeks. By the time you reach 12 weeks, the rotator cuff will have been about 70 to 80% healed, but it still takes another 9 months really to get the full benefit of that surgery. So it's a lot of rehabilitation, exercise and strengthening. With this particular technique called a double row repair, we use anchors just alongside the articular surface or the hard gristle cartilage of the shoulder joint, and then sutures are passed up into the rotator cuff and then back into anchors on the outside edge of the top of the arm. And that's designed to pull that rotator cuff tendon, which is torn off and pulled back down onto the bone so that it can then heal there. What we know about double row repair rather than a single row of anchors is that we have evidence of improved healing, less pain in the long term, and less re-tears of the rotator cuff, which is really important. Overall, the research would say that re-tearing the rotator cuff probably occurs in 20 to 40% of rotator cuff tear repairs. This is a paper or a research article showing that partial thickness re-tears of the rotator cuff are more likely to occur in single row repairs, similarly for full thickness tears. Additionally, even though we're using more anchors in the double row repair, actually the overall cost to hospitals and to the system is lower if we do a double row repair, because the occurrence of having to come back for further surgery is much lower. So I think this is really important. Just looking at treatments of arthritis, and so for a worn out joint where the ball and socket are no longer moving independently of each other, there are bone spurs and no hard or gristle cartilage left in the shoulder joint, then replacing the shoulder joint is the treatment of choice that's going to relieve the pain. Subsequently, you have improved range of motion with this treatment, although it will take some time to do that and build that up with physiotherapy treatment. The shoulder replacement can be one of 3 or 4 different types. We talk about hemiarthroplasty, which just means half replacement, where we're just replacing the ball part of the shoulder joint. And this may be in very young patients who have severe joint dysfunction. In older patients, we would recommend an anatomic replacement, which is where the socket is also replaced. And you can see in the picture on the left there, that is a polyethylene or plastic liner with 4 pegs, which is inserted onto the socket part of the shoulder joint, and the ball part of the shoulder, which is replaced. This stem would then be inserted into the top of the arm bone. The rotator cuff tendons are really important in that sort of shoulder replacement, and these are repaired robustly after the implants are inserted. A reverse replacement, which is on the right hand side of these pictures, is where the ball part is placed where the socket used to be. or onto the socket itself. And then on the top of the arm bone, a socket is fixed. And so again, usually with a stemmed prosthesis going down into the arm. In these types of implants, the rotator cuff is less important, and that's why overall in Australia, about 80% of shoulder replacements now are using reverse shoulder replacements. Additionally, in cases such as fracture, we may the reverse shoulder replacement has much better long-term function and results. This is another set of pictures just showing the anatomic replacement and the reverse shoulder replacement. Some recent advances in the reverse shoulder replacement are to use some bone grafting under the socket part. And this is to increase the offset, or to take the ball part of the shoulder replacement away from the shoulder blade. And this gives better clearance of the humerus underneath the shoulder blade itself. And we're finding that with this technique, we're achieving much better range of motion with the shoulder and achieving good pain relief as we would expect. And there's excellent evidence that this works and works in the long term. Thanks, guys.
Awesome. All right. Thank you very much. I'll get you to chuck your video on too. Thanks, Karthik. And we'll get into a few of the questions that I've had sent through. That was really awesome. Now, first question that I have here, and I'll just rattle them off for you guys, is for Karthik. Mm-hmm. How do I know if it's the right time, or if I've been in pain long enough to have an injection to then get therapy? Like, what would be the thought process, or it's a hard question to answer, but I'll throw you under the bus there, mate.
It's basically depending on your symptoms, okay? So if a patient comes and sees me and they are struggling, and I think it's a rotator cuff tendinopathy, but they can't sleep, their function in their shoulder is very poor, their quality of life is miserable, I would rather give them a corticosteroid injection to reduce the pain before subjecting someone to physiotherapy. But it would be a discussion. There would be a discussion about the pros and cons, and we talk about the risks and benefit. But generally, my approach is you try the physio first. But if they're really miserable, then I want some movement, and I want the quality of life to be restored quicker. So sooner rather than later, I suspect.
Yeah. Awesome. All right. Next one, I'll throw this one to Luke, it's about night pain. So how do you distinguish what night pain is for shoulder? Like what would you specifically be looking for? Is it someone who's got pain when they're sleeping? Is it before they go to sleep? Is it pain that stops them from being able to get to sleep? Like, how do you distinguish that?
It's often a mixture of all of the above. So it's that pain that patients are aware of when they're lying flat in bed or on their side. I think the reason that nighttime pain is often present is because the rest of the distractions of life have disappeared, and now you're starting to become aware of the things that are holding you up. So without having to do other activities, you're starting to think about the shoulder that's keeping you awake. It might be just that burning, aching feeling, that dragging feeling, just lying flat on your back, or it might be that lying on your side generates more pain. But I would classify anything that stops you from getting to sleep, or wakes you up from during sleep, or wakes you up early. Shoulders commit all of those things, and if it's disturbing sleep, then I class that as a serious problem. And usually I just ask patients, would you yourself say this is a mild, moderate, or severe problem? Because that I think it helps clarify in the person who's experiencing the symptoms' mind, but it also helps clarify in my mind that this is a big limitation on their normal function and their ability to enjoy life. And so, I think that helps focus the attention.
That's a good point. And I'm reflecting on that myself. If I don't get enough sleep, then I'm a horrible person to be around. So
it becomes a cycle, doesn't it?
Yeah. Very good. All right. The next question I have here is about rotator cuff tears, actually. And again, I don't think there's a definitive answer in this, but it's someone who's got an ultrasound on actually, I don't know how old they are. That would have been useful. But it's someone who's had an ultrasound. It's shown that they have a partial thickness tear of their rotator cuff, no muscle in particular that they've put down, and they've had pain in that shoulder for a while. Their question is this something that they should look at surgical, medical, or physiotherapy management? To whoever would like to answer that one. Do
you want to go, Luke?
Yeah, sure. I mean,
actually, maybe we'll give an answer from all three different points of view.
Okay, why don't you start off, Peter?
All right, I'll start us off. I'll kick us off. For me, I like to, if someone presents, especially if they're an older person and there's no traumatic incident involved, then I'm thinking I'd like to start with that conservative management to see, has this tear, and like I think Luke pointed out in his talk, is that a lot of people will have a rotator, 1 in 2, I think he said, over 60 has a rotator cuff tear. And the rate of actual pain associated with these is relatively low. Like when we think of a tear, we instantly think it must be painful and we're losing function, but it doesn't always work that way. So if the person was younger and it was traumatic, they fell on their arm or they're overhead athlete or something like that, I'd probably look towards that surgical management quite soon. But if it's an older person who's maybe had persistent shoulder pain for a while, they've had a scan showed up something, this tear could have been there for 10, 15 years, and pain suddenly started, and it might not be the cause. So I'd look towards conservative personally in that situation. Karthik, I'll throw it to you, mate.
Yeah. So I completely agree with that approach. It's basically, so this is where scans can be dangerous. So we don't treat the scan, we treat the patient. So if the scan shows there's a tear, but the patient can do everything, they can move their arms, they have reasonable strength, but there's a bit of pain, I would certainly send them back to the physio and say, we need to have a really good strengthening program, not just of the rotator cuff muscles, but of everything around the shoulder girdle, and give that a try for a period of time, so 6 to 12 weeks. And generally, most will get better. Like that study I quoted earlier, all those patients had full thickness tears, but 3 out of 4 got better with a good physiotherapy program. So, and like you said, if it's a young person who played footy on the weekend and now can't move their shoulder, well, then that's a different kettle of fish. That's somebody that I would be scanning. I would be doing an MRI, and figuring out what damage they've actually done to the rotator cuff, how bad are the tears, and if there are tears, I'd be seeking a surgical opinion.
And anything else you would add to that, Luke?
No, I think you're both spot on. I think for me, when I imagine the partial thickness tear or the chronic tear, the one that's just occurring over time, often from wear and tear, we talk about rotator cuff tears being, they can either be from intrinsic problems, so the tendon itself is not of the quality that it should normally be, and so therefore it starts to become inflamed and torn. And the other thing that can occur is impingement or extrinsic pressure on the rotator cuff, which is what we traditionally thought all cuff tears were due to, but we know that there's the intrinsic pathology or problem going on as well. So if the majority of people are walking around by the age of 75, say, with normal shoulders, good function, they can get their arm up over shoulder head, we know that and even though they've got the tears in the shoulder, we know that the shoulder can perform well in the majority of people with rotator cuff tears. So we want to find a way for that shoulder to return to its function with physiotherapy, exercise programming, starting off with the shoulder blade, getting the shoulder blade in the right position, and then reloading and retraining the deltoid muscle, the big sheep muscle on the outside of the arm, to start giving that range of motion and function overhead, carrying, lifting, pulling, pressing. Yeah.
Beautifully said, mate.
If that doesn't work, then we've got a good backup solution. But we always try the physiotherapy exercise-based program first. And as Karthik and yourself have said, 75 to 80% of people, that's what we need to do.
Awesome. And I think that when people come in, like half the issue, and myself included, is that rehab work is hard. Like it's a hard slog. And sometimes we don't want to do that rehab, but the reality is if you're going to go and get surgery, there's going to be quite a long period of rehab. It's not like you get surgery and you walk out and your shoulder's fine. It's you're going to be doing a fair bit of rehab. And I've actually often wondered, I'm just going off on a massive tangent here, right? With some people who don't stick to that rehab program, then we send them off for surgery. Is the real benefit the surgery they had, or that they had to stick to the rehab program afterwards? And I'd love to see a study on that one day. I don't think it'd be ethical, but I'd love to see it.
It's a really good question. Yeah.
And just one more thing on that, and real quick story here is I used to work in a CrossFit gym. That's where the physio started from, essentially. And I had a lady come in and she got a scan of both shoulders, and she had one shoulder that was in incredible pain, the other shoulder that wasn't. Now, she had an ultrasound on both shoulders, and she found that she had a full thickness tear of what's called your supraspinatus, which if you're going to tear a rotator cuff muscle, it's most likely going to be that one. And there are a whole bunch of other long words of degeneration, all this other stuff that was happening in there. And she came in and she said, I've got this and this is my pain. And I remember reading that report and going, all right, this is left-sided. And she's like, no, pain's on my right side. Like, it's interesting because the scan on the right side wasn't that bad. Like there was no full, like there was minor degenerative changes, etc. But she had this immense pain on this right-hand side. And on the left-hand side, we had a full thickness tear and a lot more going on, but that wasn't painful. But she'd come in and she obviously hadn't read the side, and she's like, oh, they must have got it wrong. We double-checked them. We found out, and ever since then, actually, when people came in and they wanted to get those scans, I encouraged them to, and this came from a guy called Adam Meekins, who's a very famous physio, to scan both sides to see if we find, especially in people over 50, degeneration or normal age-related changes, as we call it, is it on both sides? Because if we just see it on one side, we might not be getting the whole picture. If we see it on both sides, we can go, well, this side's not painful and it's got all the same things. So it helped a little bit, I think, to have a bit more information.
Yeah. And, like you say, often when you get a degeneration in one part of the shoulder, you'll often have degeneration in other parts of the shoulder. So if we've still got pain in the shoulder despite a good exercise-based program, activity avoidance, then if we're heading to surgery, usually what we'll do is target about 4 parts of the shoulder to treat simultaneously, because the last thing we want to do is have residual symptoms in another part of the shoulder that has degeneration. So we're trying to maximize the effect of surgery, minimize the amount of times you've got to redo rehab or redo surgery to get a good result and a good return to normal function without pain.
No, I love it. I've got a few more questions now. This one's interesting, actually. Frozen shoulder. So it's about frozen shoulder and just really looking at what should be the first port of call for frozen shoulder. Should they get a surgical opinion? So they're in that stage where they're frozen, they get a reasonable amount of pain, but not much movement at all. What's their best first port of call? And I know it's saying that we don't have amazing evidence behind, but what would you guys recommend?
Get a diagnosis first. Get a diagnosis. Confirm with your doctor that it's frozen shoulder. Once you get a diagnosis, then we can actually plan what the treatment can consist of. As I said, frozen shoulder, if you leave it alone, it'll go away. It can go away, but it can take a bit of time. So in terms of pain relief, that's all you can do at the first stage is pain relief and try to maintain whatever range of motion in your shoulder you have. And that's where the steroid can help. The corticosteroid into the joint can help. It can help that sticking adhesive process in the actual shoulder capsule. It can help with pain. And they also do something called hydrodilatation, which is where they put fluid and try to kind of break up some of the adhesions. And that's also possible. But that's all you can really do at the start. And then it's maintaining whatever shoulder range of motion you have. And hopefully that will give you enough function and pain relief that you can function effectively in your day-to-day life. Now, if that's not happening, well, then that's when I would be asking my surgical colleagues to help me out and help the patient out.
Awesome. There are a few options with interventional or injections into shoulders for frozen shoulder. Unfortunately, the results from them are quite variable. And so if it works for someone, that's great. But I couldn't look at 100 people with frozen shoulder and tell them all that their injection is going to work. And my advice for patients, or my discussion with patients, is really around, this is a frustrating condition. It's going to take a long time to return to normal. We can help it along, trying some injections or hydrodilatation. In terms of coming to surgery, what I generally describe is that releasing the shoulder joint will buy them better motion, and it may improve their pain at the time, but the actual process that's going on inside the shoulder will still take many months to return to normal. So the idea of the shoulder surgery is just to give a bit of relief, a bit of movement, but it will still take time.
And the follow-on question for that was, say they did have shoulder surgery for that, what does the rehab actually look like for them?
Well, my preference is to get pretty aggressive physiotherapy after surgery for frozen shoulder. So the surgery that I would offer for that is a capsular release using keyholes. So that's putting the instruments into the shoulder joint and releasing part of the lining of the shoulder joint to allow better movement of the ball on the socket. And then actually taking out some of the soft tissue that occurs in between the rotator cuff tendons to improve the motion there. And then we give it a bit of a stretch. And so by the end of this procedure, the range of motion with the patient asleep is full and complete. But by the time they wake up, it's probably back about 20 degrees from normal. So after they've woken up and they've got their pain relief, it's all about maintaining that range of motion that we've gained. So I often start off with physio appointments twice a week until we've got a steady state of movement in the shoulder. And as the patient feels like they can maintain that range of motion on a less aggressive physio program, then we can start backing it off. But that first 6 weeks is pretty important, actually.
Yeah, no, that's really good. And the last question that I've got here today, and throwing this to anyone here, is my shoulder feels pretty good when I'm at work doing sort of like manual labor stuff, but I get pain doing weird tasks. So things such as brushing my teeth, drying myself with a towel, or doing my hair. So it sounds like they're not getting pain with lifting, reasonably heavy things, but when they're doing the fine motor control, they're getting a bit of pain. So they're wondering what that could be and maybe what they should look at doing for that.
Those tasks that you mentioned, kind of overhead, your shoulder tasks behind your back, that's typically sounds like a rotator cuff tendinopathy, subacromial impingement type story. So my advice to the person asking would be get a physiotherapist to have a assessment. And is there some subtle weakness in your rotator cuff that's allowing that humeral head to kind of bunch up and squash that space in your shoulder, and that's what's causing the pain. So that's what I would suggest. I think a good physiotherapist is what they need, and some rotator cuff strengthening exercises plus the shoulder blade strengthening exercises is what they need.
Awesome. And shameless plug, look, if you need a good physio, like I do know a few down at PhysioFit, so give us a holler and we'll be able to sort you out with that one. But I can see why that seems weird. If you lift heavy things, you get no pain, and then you pick up a toothbrush and suddenly you're feeling a bit of pain there. And just to add on to what Karthik said, like I think it's being in that position, your hair, your toothbrush, and just staying in that position for a prolonged period might be the issue more than sort of lifting something heavy up, once in one smooth motion. So you can either, look at physio, maybe stop brushing your teeth, stop doing your hair, but there's probably a better option there. All right, that's all the questions I've got. So thank you very much, guys. I really appreciate your time. It's been great to have you on. For those who are watching this back, I will be posting all the links to be able to contact Dr. Luke Mooney and Dr. Karthik Badranath. So if you have persistent shoulder pain, if you've had something for 6, 12, 18 months, sometimes we get people come in, they've had it for 5 years and it's finally time to do something about it. Get a diagnosis. Find out what's actually happening there. They'll be able to direct you to whether you do need physio, whether you do need some kind of injection to allow that to happen, or whether surgery is your best option. These guys are really amazing. We refer a lot of people to them. We trust them very highly. They do great work. It's been a pleasure to have you guys on.
Thanks, Peter.
Thank you.
Awesome. All right. Until next time, my friends, we'll see you later.